everyone. Welcome to our Coastal Quickie. I'm Dr. Jessica McLaughlin. I'm one of the physicians here at Coastal Fertility, and we are continuing our series where we try to take a little bit of extra time to dive into some specific topics. So I'm very excited to talk about ovulation, induction, and intrauterine insemination this evening. And so I'm going to be going through some of that because we are on Facebook Live. Certainly, if there are questions, please write them in and we'll try to address them along the way. So some of the goals of tonight, to think about treatment, first we need to think about that evaluation portion. So we'll go through some of the basic infertility evaluation, and then we'll kind of dive into some treatment options, specifically ovulation, induction, and IUI, and we'll get into different medicines that are used and how they work and what is monitoring like and what to expect. And then we'll think about, who is a good candidate for this treatment and think about expectations and success rates from this treatment. So we're going to get started. Again, one of the most important things is, thinking about, well, who should we even start this workup in? So infertility is defined as trying for pregnancy, so being together without birth control for 12 months. So if you are under 35 and have been trying for fertility for for greater than 12 months, that's a reason to come see us. If you're over 35 and we think about seeing you a little bit sooner at the 6-month mark, and as we get closer and closer to 40, that's when we're generally kind of starting the evaluation right away. Now, we can certainly start it earlier if we have a concern that something may be going on. We have a concern that there's endometriosis, or that we're not ovulating normally, or there's a problem with the fallopian tubes. All those would be reasons really not to wait that full kind of 12-month period and to start the evaluation a little bit earlier. And so when we think about the evaluation, I like to be very, very systematic, and that's, we're going to think about all those big categories that can affect fertility, because that lets us be very thoughtful about what is the appropriate treatment. And so the big categories to think about, let's think about the ovaries, let's think about anatomic things, and let's think about sperm. And so from an ovary standpoint, really two important questions. And that first question seems so simple, but is so important. Just, are you ovulating normally? And a great window to that is just learning about your menstrual cycle. So just taking a menstrual history will often give us insight into if you're having a regular ovulation. It's normal to have a little bit of variance in the number of days, but if you are generally having a period every month, that's really good evidence for ovulation. Now, if you're not having a period every month, that's going to prompt us to do different things. Maybe we do an evaluation for PCOS, or maybe we think about your thyroid or a prolactin hormone. So certainly, again, back to our main category of ovaries, question number 1 is, are you ovulating normally? Question number 2 is thinking about, well, what is my ovarian reserve? And what that terminology refers to is overall egg quantity and quality. And something that makes us as females very unique is that we're born with all the eggs we're ever going to have, and we just use them throughout our life. It's natural, it's normal, and we just want to find out where you are in that process. So, really my number 1 marker is looking at age. Other things we can do is that we will look at the ovaries and see how many eggs are in the group that month. It's a resting egg count called an antral follicle count. Other things we can do is through a lab evaluation. We get specific hormones at the beginning of a menstrual cycle, something called follicle stimulating hormone. We're going to be talking a lot about that hormone this evening, but FSH is the hormone that comes from the brain and talks to your ovary. So the word follicle, what that means, it's a little fluid area in the ovary that contains the egg. So this is the hormone that stimulates the eggs. And so when we measure that to look at ovarian reserve, I'm seeing at baseline, how hard is your brain having to work to push your ovary? So that's an important hormone to me. And then the other hormone we look at for the ovary is called AMH, anti-Mullerian hormone. It is made made by all these little microscopic eggs in the ovaries, and it's an overall nice marker for the number of eggs. So again, first big category, ovaries, 2 questions. 1, are you ovulating normally? 1, what is ovarian reserve? The second kind of big category is thinking about anatomy things, and we think about the uterus and the fallopian tubes, and the way we do that evaluation is just starting with an ultrasound. That's a great way to look at the outside of the uterus. I can see your ovaries. What I can't see on ultrasound is the inside of the uterus, or where a baby implants, or I can't see the fallopian tubes. And so that's why we use a special test called an HSG, or hysterosalpingogram, and it lets me put a little catheter in the cervix. I put some dye on the inside so I can see the inside of the uterus. If those tubes are open, I'll be able to see that dye going out the tube. So that's really a nice way, in addition to the ultrasound, to look at anatomic things. And then that last category is looking at sperm. And so that we do that by doing a semen analysis. So again, doing that infertility evaluation, very, very important to have an idea about what is, causing my infertility, what is the overall kind of prognosis for live birth, and, overall decreasing health risks for patients and future baby. And it lets me, help determine, what should we do as next steps? What is an appropriate treatment? So always certainly kind of starting with the evaluation. And then we'll kind of think, well, sometimes we are ready to get into treatment, and one of those treatments is ovarian stimulation or ovulation induction. And I think it's so critical to understand, how does this normally work, to really understand, well, how does the medicine work, or how does this treatment work? So what happens just in a very normal menstrual cycle, probably many of you know that just 1 egg is released each month, and how that actually happens, again, back to that hormone we mentioned, that follicle stimulating hormone, the hormone from the brain. So that hormone comes from the pituitary gland, and from the pituitary gland, this FSH is released, and it goes down to talk to your ovary and starts activating the follicles in the ovary. And those follicles start making enough hormone, and it sends a little feedback loop back up to the brain, so that only a small amount of that FSH hormone is released, just enough to stimulate 1 egg each month. So it's a very, pathway between the brain and the ovary, and back to the ovary to the brain, so that we're getting enough hormone from the brain to stimulate one follicle, 1 egg each month. So that's what usually will happen each month. And when that egg is mature, it's actually going to cause the brain to release a hormone called LH, and that's what's going to help you to ovulate. So it's all a very coordinated events between the brain and the ovary. So that's all very good to understand before we kind of, start thinking about, well, how do the medicines work, and, what are the goals of the treatment. So goals of treatment in general, it can actually be a little bit different just depending on the patient. So let's think about one patient first. Let's use an example. Let's say that you're coming to see me and you don't have a regular period. Maybe you have polycystic ovarian syndrome and you do not ovulate normally. Well, my goal of a treatment is really just to get you to ovulate 1 egg. If we can get you to have 1 egg, then that is a success. So the goal of ovulation induction for that specific patient is really just for 1 follicle. Now, let's take a couple that we've done their evaluation. They actually ovulate every month. Maybe they have unexplained infertility. That's where we think about ovarian stimulation with the goal of, potentially getting you to ovulate more than 1 egg. So that's really, in that instance, how pregnancy rates are increased, because we already are naturally ovulating that 1 follicle. Maybe we give you medicine to ramp that up a little bit, and maybe we get 2 to 3 follicles. So again, these are all examples of ovulation induction, but just know the goal is a little bit different, just depending on, that specific patient. So with these medicines, we may help you form 1 follicle or multiple follicles, again, depending on what our goal is for the treatment. And we do this in different ways. So there are, in general, are 2 categories. One is oral medications, medicines that you take by mouth, or injection medicines. And so the oral medications, some names you may have heard, are Clomid and Letrozole. They work slightly different, but the goal is that they increase the FSH hormone from the brain. So what they do, and again, both of them work a little bit differently. Clomid works at the level of the brain and tells the brain that there's not enough estrogen around, and therefore the brain's response is more FSH hormone. Letrozole does something similar in the periphery. It says there's not enough estrogen there, and therefore increases that hormone coming from the brain. So either way, it's a medicine you take by mouth to get more hormone from the brain that's going to stimulate the ovaries. Now, if you've ever heard of injection medicine, what the injection medicine is directly that FSH hormone. So we're able to give you back FSH just as an injection that you would give yourself. So there are different medicines we can use. Again, those are the oral medicines and the injections, and the goal being we help you to form one follicle, potentially more than one follicle, during a stimulation. So you would take these medicines, and then importantly, we need to monitor. And so the way that we monitor is through an ultrasound and with blood work. So on ultrasound, I'm looking for kind of follicular growth to see if I can see kind of a single or multiple kind of dominant follicles, eggs growing in the ovary forming. And then I'm often also looking with blood work that tells me, is this making estrogen, and where is your body in the process of is it getting ready to ovulate, or do we need to give a medicine to help you ovulate? So generally, the amount of time it takes to stimulate the ovaries can vary. I would say maybe an average is approximately 7 to 10 days, but it's all different, and we're watching. So we're, it's so important to monitoring during this so we know how those ovaries are responding and can make appropriate adjustments. Once we do get a mature egg, then we can give a medicine to actually start that ovulation process. So if you've ever heard of a trigger shot, what that is, it's the HCG hormone. It simulates the LH hormone from the brain. So again, kind of when we talk through, what naturally happens, we are just helping that natural process. So we are going to simulate the LH hormone that comes from the brain that's going to make you ovulate. And so then we've done everything we could from an egg standpoint. The next thing we need to do is from the sperm standpoint. So our job is to appropriately time sperm getting there at the right time. And so that is something called intrauterine insemination, or an IUI. What that is that, a partner would come in, or use of donor sperm. We would wash and concentrate sperm. This sounds maybe weird or odd, but everybody has dead sperm, has debris. It's normal. So we need to wash and concentrate the sperm. And then with a little catheter, we're going to take the little catheter and put it up to the top of the uterus, and put sperm to the top of the uterus. And so naturally, sperm is weeded out in the vagina and the cervix. It's normal. And where egg and sperm meet is actually in the fallopian tube. So we are getting those eggs coming down the fallopian tube. We are getting sperm in the uterus. And so those are really the closest that I can get those two things together at an appropriate time. So in general, doing an IUI, approximately doubles pregnancy rates compared to just intercourse, and that's why we're concentrating the sperm and we're getting the sperm kind of past those points of general kind of loss in the vagina and the cervix. So risks to think about from this, I think that's always an important question. What are possible risks? I think really the main, thing to know, I think patients really do quite well with the medicine as far as there's not a lot of side effects, but the thing to know about the real risk is a potential risk of multiples, and that's something we are very aware of, counseling patients about and looking for. And so the multiples risk is related to which medicine you take. So if we take just those medicines by mouth, the Clomid and Letrozole medicines, the multiples risk is approximately 8 to 10%. Again, most of those are twins, very rarely anything more than that. When we add injections in, we get a slight bump in overall success rates, but we also see a bump in multiples rate, and that's also something to be very aware of. And one of the many reasons, this is really a process that needs to be monitored. So we really need to know how you're responding on ultrasound. So when we are using just injection medicine, the multiples risk is in the 15 to 20% range. Again, still most of the time twins. And a perfect kind of ovulation induction for someone who already ovulates is 2 follicles. So that is increasing pregnancy rate by getting you to ovulate more than 1. So in general, very important to be monitored. This is a risk and something that, we don't want you ovulating too many follicles, but is why we are watching how the ovaries are responding and keeping that risk as low as we can for you. The other possible risk, just if we were to kind of think of everything, is something called ovarian stimulation syndrome. That's getting sick from having a really high estrogen level. So if you have a lot of follicles making estrogen, potentially that can cause fluid shifts in our body and can cause, different things, but, severe things, fluid in the lungs, fluid in other spaces. That would be very rare with ovulation induction. With oral medicines, extremely rare. With injection medicine, still the risk of a severe ovarian hyperstimulation, would be in the 1% or less range. And again, most of the time we are increasing your estrogen level, but only an increase that is appropriate for having kind of 1 to max 3 follicles. So that is something that exists out there, but is overall, thankfully, a rare thing when we're doing this sort of treatment. So let's say we want to do this, what to expect? I think just one thing to know is just from a time frame standpoint. So generally, this, certainly can vary, but in general, ovarian stimulation with an IUI takes approximately 1 month. So sometimes it takes a little bit longer to get ovaries to stimulate. Let's say we're doing this for the first time and we're finding, how much of a dose the ovaries will respond to. Sometimes we're learning about ovaries like that, but in general, somewhere around a 1 month time frame. After we do the IUI, we'll get a pregnancy test about 2 weeks later. And so that's what to anticipate during that waiting period. And then, success rates. I think, this is an important thing to consider. So I think, first let's just ask a question of what is a natural fertility rate. I think this is really, important to know when we think about success rates. So let's take, this is just an example, let's take a 25-year-old couple and, they don't have infertility, they don't have any problems, they're just, trying for pregnancy that month. What's the chance they're going to conceive? And that is about 15 to 20%. So natural fertility at max about 20%, per month, which is a lot lower than most of us, may think it is. And so when we think about, let's take now that same 25-year-old couple who's been trying for pregnancy for 1 to 2 years, and we do their evaluation. It's consistent with unexplained infertility. Everything is otherwise normal on our evaluation. Well, now they're at a per month success rate and really more of a 2% kind of range. So if we want to start with this simple fertility treatment, it will often bring us back to a baseline fertility rate per try. So this is different, for every couple based on their age and their factors, that we've identified. But again, using our example of a couple under 35 that, the evaluation is consistent with unexplained infertility, per try, success rates would be in a 15 to 20% range, which again will bring us kind of closer to a natural fertility rate kind of per month, which is why, it's a very reasonable approach, if we are in that scenario of let's try something simple a couple of times. Because if we think about cumulative success rates of a simple fertility treatment, maybe 3 times, well, that becomes a very reasonable thing to do. So, of course, success rates are going to vary based on age. So what is a natural fertility rate? Again, these are not people that have infertility, but a natural fertility rate, just by the time we are 40, it's going to be 5% per month. It's normal. That's just kind of what happens happens with ovaries. So if otherwise, let's take again that 40-year-old couple, we do their evaluation and all we find is just age, is that, you know, the success rate per try is going to be in a 5% rate per try. So it will increase us certainly from our baseline fertility rate, but, you know, it will often, it's helpful to think of what is, you know, per my age and the factors that's been identified in my infertility evaluation when thinking about success rates. So, thinking about, you know, all that, you know, a question, you know, I often get is, you know, is this a good treatment for me? Is ovarian stimulation with IUI, you know, one of our simpler fertility treatments? Is this work for me? Is this a good option? I think who we think of this often in as you know, great, you know, first steps, specifically as in, you know, a patient or couple that has anovulation, so meaning that you don't ovulate normally. So a great treatment for you in that case is getting you to ovulate. And so that there's many reasons a woman may not ovulate normally. She may have polycystic ovarian syndrome, something called hypothalamic amenorrhea, not enough hormones coming from the brain talking to the ovaries. So there can be different reasons why, but if the reason for infertility is anovulation, then this would be you're a great candidate for a simple fertility treatment. The other, you know, candidate I often think about is unexplained infertility. That is where we've looked in all of our big categories. We've looked at ovaries and sperm and anatomy things. We don't find anything. And so really what we call empiric treatment is getting the ovaries, stimulating those ovaries and combining it with sperm with an IUI. So there are other, I would say less common, you know, reasons that we're doing that, but, you know, sometimes there is maybe a mild male factor. There's enough sperm there to do an IUI, but we have noticed a mild male factor, and sometimes an IUI can be appropriate in those times. Sometimes there's, you know, problems with erectile dysfunction or painful intercourse that an IUI can be appropriate with. Sometimes we're using donor sperm, and, you know, that's the reason for an IUI, or, you know, less commonly problems with the cervix. So there can certainly, you know, be other, you know, scenarios that we're kind of thinking about ovulation induction with IUI. So I think, you know, to summarize, I think there are many couples out there that can be treated very effectively by doing simple things, what we consider more of these low-tech kind of fertility treatments. To know, though, if you're a good candidate for that, you know, it's certainly talking with your trusted doctor, doing your evaluation, because we can never say up front, you know, without knowing if tubes are open and all those really important, you know, components, you know, if this is really the right treatment for you. So if you are out there and kind of thinking about, you know, kind of seeking, you know, a conversation or an evaluation or treatment, I encourage you to do so. I think, you know, the biggest, you know, message is most couples who choose to pursue treatment will ultimately be successful, and with persistence, we have success. So really that first step is starting the conversation, and that's what we're here for. So I'm going to pause there. Any questions?
Yes.
Okay. Holly is here as my assistant, so she's going to be asking some questions.
Okay, so I have Caroline, and she wants to know, for PCOS patients who have had some unsuccessful medication/timed intercourse cycles, do you generally prefer to move to IUI next, or do you skip to IVF?
That's a great question. So she was asking, you know, if we've had some timed intercourse cycles, should we move on to IUI, or should we move on to IVF? I think one of the first, you know, questions I have when hearing that question is knowing, you know, do we have a good response, you know, to the timed intercourse cycles? Because sometimes it's hard to know if we weren't kind of monitored, you know, during those cycles. So I think if we were monitored and we know we had a good, you know, response, you know, to the ovarian stimulation medicine, and we truly don't ovulate on our own, then we have, you know, really tried, you know, combining an egg together with sperm, you know, at the right time. So, you know, in those scenarios, it's, you know, not wrong to do simpler fertility treatment. You know, I certainly wouldn't do probably more than another 3 cycles, but is the appropriate time to start at least having a conversation about IVF. So, I think if truly we've had, a proven kind of response at that point, I do think it's appropriate to be thinking about IVF. That is never a black and white answer. And so we'd, want to see the rest of the evaluation, and are there any other factors at play?
Okay. Daisy is asking, what is the success rate of an oral and injection IUI cycle with a trigger shot? She's doing it tomorrow.
Yeah, so that's often what we do here. So it's combining, optimizing success rates with using kind of the injection medicines, but we use those at a low dose, so we're not increasing the multiples risk too high. So that success rate per cycle is in a 15 to 20% range.
Great. And then Allison wants to know, can you tell me if there is an age cutoff? Also, is IUI always a starting point?
Yeah, so there's really 9 age cutoff. What we want to do is be able to give you expectations from different kind of treatments. So, if you, came to see me at age 40, that doesn't mean that we can't do IUI, but it means that we should do an evaluation, and then I can give you my best medical estimates and options for kind of different treatments out there. So, I would say sometimes we do think about IVF as kind of the first step, but, we will go through different options and best medical estimates, for each of those, so that, we can have an informed kind of decision making together.
Amber would like to know, would you recommend an IUI with a blocked tube?
So, it all depends, what kind of blockage there is. So, let's just use an example. Let's say the tube is proximally occluded. That means a blockage at the beginning of the tube close to the uterus. Sometimes we do fertility treatment if we're ovulating on the other side. So, that is an option. If we truly have a blocked tube kind of on that side and are planning to use that side, I wouldn't recommend that. That's where, I would think we have a decreased success rate. But the other thing, unfortunately, if that tube isn't working well, that's where we start to see an increase for something called an ectopic pregnancy, or a pregnancy getting stuck in the tube. Good question.
And I think that's all.
Okay.
Wait, one more.
Oh,
Monique, for the last couple of months, my period stays on one day. Can I still get pregnant?
So having a shorter, it seems like a question about having kind of a shorter menstrual cycle day. So the days that you bleed, that can really vary. So that you have a period though each month is very reassuring. I would still kind of go through those main kind of categories that we talked about, thinking about ovaries, anatomy, and sperm, but that you're having a bleed, each month is a good starting point, for learning about your ovulation.
Okay.
All right. Well, I think those are all the questions. So thank you for joining me this evening. You can always call us at 843-883-5800 or just coastalfertilityspecialist.com. Please join us next time. We're going to kind of take a deeper dive into IVF at that time and get into those nitty gritties. So thank you so much. It was wonderful speaking with you all. Take care.